Good morning and welcome to Webinar Wednesday presented by Palmetto Care Connections. This webinar is a part of the Telehealth Research and Report series by the Medical University of South Carolina. Before we begin, I'd like to announce that this webinar is being recorded for educational purposes. The webinar recording and slides will be posted to PCC's website after the webinar has ended. The webinar slides are also available in the handout section of the navigation bar. If you have any questions during the webinar, please use the chat or question box. At this time, I'd like to turn the portion of the webinar over to Ryan Cruz.
Good morning, everyone, and thank you, Davia. We are very excited for this webinar today. This is our third Research and Reports webinar as part of our series. This webinar we've been doing in conjunction with two grants that we have. One is a grant from the Agency for Healthcare Research and Quality, and the other is our National Telehealth Center of Excellence grant. Palmetto Care Connections has been an awesome partner with us in helping disseminate some of the research that we're doing and making sure that the research that we're doing makes it back out into the community here in South Carolina. So thank you to Palmetto Care Connections for working with us on that. Today, I'm really excited because we have a panel of various researchers here at MUSC doing lots of different and innovative work in the telehealth research space. And so the way that today is going to work is we're going to have Dr. Brown start us off talking about a project she did looking at provider and health system leadership perspectives on ambulatory expansion during COVID. Then Dr. Simpson and myself will be talking a little bit about some heat mapping that we've done to inform telehealth strategy. And then lastly, Dr. Williams is going to be sharing some of the work he is working on in the telehealth and rural hospital finance space. Throughout the time, I'd encourage you all to use the chat to ask questions. We'll leave a little bit of time after each of these for the panelists to answer questions about their presentation. And additionally, we'll have some time at the end, assuming things don't go long, for all of the panelists to answer some questions. So if you feel free to ask questions throughout the whole process for any of our speakers, and we'll try to make sure they get answered. With that said, I am going to start by introducing Dr. Elizabeth Brown. Dr. Elizabeth Brown is an academic educator and health services researcher who focuses on social determinants of health, particularly race, ethnicity, access to primary care, healthcare policy, and chronic conditions. She is also interested in examining privilege as a social determinant of health and the effects of race and racism with healthcare providers, students, faculty, and staff. Dr. Brown received her undergraduate degree in English journalism from Columbia College in Columbia, South Carolina. She has a graduate degree in public administration from Walden University, and her PhD is in health and rehabilitation sciences with a focus on health services research from MUSC. So with that, I'm going to kick it over to Elizabeth, who is going to be talking about this research.
Good morning. I'm happy to be here this morning talking about some of our work that we've done. And I'm going to talk about ambulatory telehealth and some of the approaches that were taken during COVID-19 and really focusing in on those facilitators, challenges, and next steps. So some background information. I won't stay on this slide too long because many of us experienced this COVID-19 pandemic and how it forced our healthcare systems to quickly adopt and adapt telehealth services. And what we felt was these national organizations and their policies that made telehealth a bit more flexible for folks. So broadening telehealth services, allowing patients to see providers across state lines. We saw where CMS actually relaxed compliance requirements where providers could use video communication like Zoom and Skype to see with to work with patients. Here in our own state, we saw temporary policy changes promoting telehealth flexibilities during the COVID-19 public health emergency. And even at our own institution at MUSC, we saw where clinic volumes declined just due to the rapid response to COVID-19. And again, when we think about those stay-at-home orders, different policies that were coming through, we had to keep our providers and our patients safe. I will also note that ambulatory telehealth visits jumped from 1% to 66% just during the first 3 weeks of the pandemic. So our research question and study aim for this particular project, the research question, which program transformations went well or according to plan, and where did we have challenges. So how we did this was we wanted to investigate how telehealth leaders, ambulatory care managers, and providers, and leaders in compliance and finance, how they transformed ambulatory telehealth infrastructure, and then also how they characterized challenges, facilitators, and successes during the pandemic. So I'm going to talk about the methods. What did we do to carry out this particular study? This was a qualitative study using semi-structured key informant interviews. So these interviews were conducted via Zoom or Microsoft Teams in the fall of 2021. We went with a conventional content analysis, which really just allows us flexibility to explore participants' experiences and see how they describe this phenomenon. This allowed us to have open coding of their transcripts, so of the interviews that we transcribed, to identify emerging themes. We also use non-probability purposeful snowball sampling. I know that's a mouthful, but essentially this allowed us to brainstorm experts, knowledgeable individuals to interview. Who were those individuals on the front lines during this transition, this rapid response? And then at the end of the interviews, we asked the interviewee for suggestions for more participants. The participants included telehealth leaders, ambulatory providers, and also leaders in finance and compliance. So I'm going to talk a little bit about the data collection piece of this. So our interview guides, they were open-ended questions, and we had 4 modules. The first module was verification of activities. What were these individuals doing? What did those transformations look like, and what transformations took place? We also asked them about successes. So what went well during the implementation of these COVID-19 responses? We asked them about lessons learned. So what were some of the challenges or lessons learned throughout this process? And the last module was kind of a wrap up those ending questions. And one of the questions was, what advice would you give to other telehealth leaders and providers? We did allow for follow-up or probing questions for clarification and to promote dialogue. So interviews lasted between 23 to 74 minutes, and they were about an average of 41 minutes, and we had 16 participants. So I'm going to talk a little bit about the data analysis and also the ethical review. So these interviews, they were recorded via Teams or Zoom, and then they were sent to a third party to transcribe them. 2 coders, including myself, we met virtually for 4 months. And what we did was we read each of these transcripts, we coded them individually, and then we wrote a memo at the end of these coded transcripts. And that memo just really helped us kind of clear our thoughts. What really stuck out to us here? Did we have any questions? Was anything really interesting for us? And then from that, we developed and continuously refined a code book. If I counted correctly, it looks like it was 4 times we went through this. And then we would get the coded transcripts, we would switch them, reread them, recode them. And this was just to help establish consensus. And anytime we disagreed or we even agreed, we discussed, why are we disagreeing? Why are we adding additional codes or need to take out some? And then we started looking at those emerging themes. And if you look to the right side of the screen, I actually have a part of our code book. So you can kind of see the code and then the definition and what we were looking for in those transcripts. And I should mention that we did have Irb Approval. This was approved as quality improvement and program evaluation. So I'm going to talk about some of those results from this qualitative study. When talking about the facilitators, the major things that came up were the reimbursement changes. So that was from the policies, stuff that I kind of talked about in the first part of this, the urgency and nimbleness, the leadership support, Stakeholder relationships. And I think one of the biggest ones that kept coming through was the ability to build off an already existing telehealth infrastructure. I have some quotes over to the right side of the screen, and the one that really kind of stood out to me was, I feel like I've spent the first 10 years in telehealth trying to convince people that this could be done, and then in like a week, everyone's doing it, like, oh yeah, this can be done. So just as we had facilitators, we also had some challenges with COVID-19 and the response to COVID-19 as far as telehealth goes. So while urgency and the rapid pace were considered facilitators for helping telehealth, they were also determined to be challenges because this created, workload and workflow challenges. Also, another challenge that came through was, the balance between centralized decisions and the individual service line workflow needs. They just didn't align. So those were two of the main challenges that came through. Again, here we're going to talk about successes, but again, we see that rapid transformation is in the facilitators, the challenges, and now also the successes. But that rapid transformation to facilitate telehealth, that was a success. Hiring and training of new advanced practice providers, educating those different providers, especially those who are new to telehealth. And the last one of my personal favorites, is patient engagement and access piece. And again, I have two quotes off to the right side of the screen. And the one that kind of stood out to me was, I think this was a big success to manage and adapt our workflow with telehealth. And we did it so in a manner that patients aren't left out in the cold. So I love kind of how the patient engagement and patient access is coming through in the success piece of this. So some next steps, we ask providers and leaders, finance and compliance, what are the next steps as we move forward? And it's really to determine the appropriate mix of in-person and telehealth, not only for patients, but also consider provider schedules regarding the mix of in-person and telehealth. So thinking about that for patients, but also what does that look like for providers? The third piece is examining and redesigning some quick decisions regarding the workflow and the use of space. And I'll give an example regarding the use of space. One thing that came through was, if providers are doing telehealth and they're at home, what do we do with this space, this clinic space? Another thing that was mentioned was if providers are in the clinic, we need to make sure they have a room that is quiet, there's no interruptions, where they can meet with patients virtually. The last piece was following the reimbursement policies and advocating for policy changes that support telehealth outside of this public health emergency. Again, some more quotes on the right side of the screen. And that top quote, they're talking about, well, we're going to reimburse while we're in this public health emergency, but we really need to think towards the future and say, okay, this is an investment. We need to reimburse because this is the way healthcare is moving. So really quickly, I'll go through some discussion points. So feasibility, given how this was done as a rapid response to COVID-19, it shows promise that this is a good approach to deliver care to a wider audience than pre-COVID, pre-pandemic numbers. And the other piece that I want to hit on is sustainability. That came through a lot, especially as far as challenges. How do we overcome those significant reimbursement and workflow issues to remain sustainable? Healthcare systems are seeking sustainable balance between telehealth and in-person. So what does that look like for the patient? What does that look like for the provider? And in all of these, all stakeholder groups need to be involved in these decisions, including patients. The last piece is, researchers need to really drill down into the patient experience and determine if telehealth services are equitable and they're not contributing to health disparities. So a few implications related to policy and practice. We need to address these reimbursement policies outside of public health emergencies. So with the right supports in place, you heard those earlier, having leadership, having that policy change or reimbursement policies change, Providers can offer quality care to patients, particularly to underserved communities. We need to be identifying and supporting those vulnerable populations as we develop telehealth programs. Um, we can accommodate those who are homeless or speaking English as a second language to improve access to care. And that was actually discussed in some of the interviews. We had providers who were reaching out to individuals who were homeless or individuals who didn't speak English as a first language. Telehealth, the expansion of telehealth could potentially help provider shortages. We could train more of those advanced practice providers to support telehealth initiatives and increase access to provider and services. The last piece is potentially decreasing high healthcare costs, including like transportation costs, and improving patient satisfaction. Patients may feel the benefit of telehealth. This may be especially true for patients living with chronic conditions who may have to seek out healthcare services more than others, especially those in rural areas or who live further from their providers. And actually, some of our next steps at MUSC are to explore patient perspectives concerning telehealth services. So again, drilling down into that patient perspective and make sure we're not contributing to health disparities that I mentioned in an earlier slide. So here are the references if anyone is interested.
Yeah, it looks like we have time for one question. So if folks have any questions, please feel free to chat them into the question box. While we're waiting to see if any come in, Elizabeth, just a question from you. I'm curious. I know that a lot of your findings were really rooted in the data and the interviews, but as you were speaking with folks and these different leaders, was there a certain mood or a tenor, or like how were people talking about telehealth and the future of telehealth? What were their general feelings and expectations, just from your perception?
I got that it was, while it's a challenge, it's still an opportunity. They're looking forward to this. I kind of felt like this is the way of the future. It's here to stay. We just have to figure out how it's going to be sustainable. And I think those came through in some of those themes.
Great. And I'm not seeing any other questions right now. Are you seeing any, Davia?
No, not at this time. We haven't had any questions about Elizabeth's section. Some might come in later.
Excellent. Well, folks, feel free to chat in your questions. We can pick them up at the end. And thank you so much, Elizabeth, for the presentation. I'm going to be flipping now over to our next topic. And before I do that, I want to do some introductions. I realize I didn't introduce myself. I'm Ryan Cruz. I'm our Director of Research and Grants at MUSC's Center for Telehealth. I've been with the center for about 5 years now, and in my current role, I oversee our data, outcomes, and various grant initiatives, including working on our Telehealth Center of Excellence grant. I am also a PhD student studying under Dr. Simpson and some others in health services research myself. Dr. Simpson, I'll introduce her now. Dr. Simpson is an embedded researcher at the Center for Telehealth at MUSC. In this role, Dr. Simpson leads a team of qualitative and quantitative research specialists on studies to document the effects of telehealth access, quality of care, and cost improvement. She is also the director of the MUSC Comparative Effectiveness Data Analytics Core, which focuses on using EHR and billing data to evaluate health program outcomes and cost effectiveness, some of which we will see today. Dr. Simpson has an MPH and a DRPH degree from the UNC School of Public Health and was a Robert Wood Johnson Finance Fellow at Johns Hopkins University. She has been faculty member at MUSC for 24 years and is a university distinguished professor in departments of healthcare leadership and management and in public health science. So with that, I'm going to get us started with this conversation, and I'll kick us off by talking a little bit about the context of why we did this. So for folks who are, many of you already know this, but for folks who may be unaware, MUSC is the headquarters of the South Carolina Telehealth Alliance. The South Carolina legislature has invested a fair amount of funding in telehealth and telehealth infrastructure here at the state. And those funds flow through MUSC, but go out to a lot of different community partners. And each year we work closely with other health systems, other community partners as part of our big strategic plan. Over the last couple of years, we've sort of revamped and rethought how we do our strategic plan. And I'll show you what that looks like in a second. But I do have listed here a website for you to look at and learn more. But anyway, as we were rethinking our strategic plan, working with our partners and really trying to demonstrate the value that we bring to the state in all of these telehealth initiatives, what we ended up doing is restructuring the strategic plan around those value cases. What value is telehealth bringing to the state of South Carolina, and how is the funding here in South Carolina being used to get that value? And so we really bucketed it into these 7 different strategies. And I won't dive into them in depth. Feel free to check the strategic plan out, but they really boil down to how are we supporting our hospitals around the state? How are we increasing access to ambulatory specialty services in the state? How about primary care? How are we supporting our primary care providers in the state with their needs? How are we using telehealth to reduce health disparities across South Carolina? What about expanding access to convenient care for patients, making access more convenient? And then the last 2 is looking at businesses and institutions. So we have a fair number of businesses and institutions like our Department of Corrections, like various universities and colleges. How can we support them through telehealth? And then how can we reduce the cost of healthcare through cost avoidance using telehealth? So we have reshifted how we do all of our reporting in our annual report. It's all based on these various strategies. And then our strategic plan is all rooted in these various strategies. So one of the things we really wanted to do as we made this shift and started focusing on value is to look at the data and make sure that we're actually making a dent across these different buckets. And so that is really what paved the way or set the groundwork for the project Kit and I are going to talk to you a little bit about today. So some of the questions we really wanted to answer is how can we make data-informed decisions about deploying telehealth strategically to truly address gaps in care? It's not going to work if we're building telehealth clinics in places where there's already a lot of access. We want to make sure those clinics are based in places that lack that access. Similarly, how are we moving the needle across the board? And then the other big piece of this that I think is really important is how can we make these data easily digestible for broad stakeholder audiences, as well as make it impactful for policymakers. As I mentioned, the state legislature here in South Carolina funds a lot of our telehealth initiatives. We want to show and make the case that we're making a dent and make that in a visually digestible way. And so when thinking about this, we landed on using healthcare utilization geographic heat mapping. This is an example of a heat map I pulled from the New York Times. I would love to venture any guesses of what it's a heat map of, but since you don't have an opportunity to chime in, these are Beyonce YouTube streams from 2017. She just released her new album, so I've been thinking a lot about Beyonce lately. As you can see, the South has good taste in music. So with that said, we decided to, I'll kind of give a high level overview of the project and then kick it over to Kit to talk about the methods. What we did is we picked 3 different value strategies that we thought we had data that would be easily available to show this heat mapping as sort of a proof of concept. And so we picked hospital support, service extension. So this being how are our hospitals, are we extending access to specialty care to all of our hospitals in South Carolina? Service extension, to what extent do various communities around the state have access to specialties? And then convenient care, and how is our virtual urgent care platform getting used across the board? This one is particularly important as we have used a lot of virtual urgent care during COVID to help triage and screen patients for testing. And so with that being a large public health intervention, we wanted to see, is it in fact reaching all communities? So the goal was really to demonstrate gaps in access or show how patterns of care might be mitigated using telehealth through these heat maps. And we wanted to use easily accessible claims or other statewide data sources when possible. As folks know, in telehealth research, it's really hard when there's a lot of different health systems that have data to combine that to give a statewide view. So really using claims data is a good way to get the most universal view of that. And then we wanted to make sure that these weren't just an academic research, but that we could use these to inform the strategy of for our strategic plan going forward. So with that, I'm going to kick it over to Kit, who's going to talk a little bit about what we did for each of these three value areas.
Yes, and I'm delighted to come after Dr. Brown and Ryan, because if you think about it, I was introduced with a lot of different titles and so on and so forth, but I'm really the untapped data wrangler for the telehealth. And it's very, very important if you think about it. The unique thing that we have been fortunate enough to generate here is we have Dr. Brown embedded to analyze and collect the qualitative impression data from the leadership and from the on-ground managers. That informs a lot of questions about what went on. And then what Ryan and the leadership group did was look at trying to develop strategies. But if you think about it, Dr. Brown brought some issues up about access and equity and responses and so on. And we used the method of heat mapping, which requires data. Now, words are data, but these are numerical data from really big databases. And I just want to tell you what heat maps can do because it's really important. Heat maps, just as the one that showed Beyonce, can tell you who gets the telehealth services. What is the reach that we have? It can also tell you who is getting services that are equitable. That's when we do the heat maps by populations. That's where we can rank who's getting a lot. So we need to look at our reach. We need to look at with heat maps at our equity. And then we need to use the heat maps to design the future strategy so that we can reach out where there is the greatest chance of improving equity. And that is how the whole thing fits together. So we did that, and we developed some new methods and used some available data that are really, really interesting in that people never utilize the data they have. They don't squeeze the data. They don't make the data sing. And that's where you need somebody who really enjoys this. And I'm that person. I do it for fun on a Sunday afternoon when it's raining. And so what we looked at first was using the heat map to find the gaps in access for specialty outpatient care, to demonstrate what could happen if we strategically deployed our telehealth services. And we used the Medicare National data set. It is just a 5% sample. And I like big volumes of data. So that was pretty thin because it's a 5% sample of the 800,000 Medicare patients in South Carolina and what kind of outpatient specialty services they used. And I took those data and I identified the specialty visits by CPT code filters. And I also used the physician categories. And we actually, I'm just going to show you some of them, but we really pulled the data for internal medicine, cardiology, neurology, endocrinology, infectious diseases, rheumatology, and psychiatry, and also surgery. But we're not going to show you all of those because we haven't quite finished the analysis. There are not too many rainy Sunday afternoons that are available. So we identify the outpatient specialty visits through the CPT codes in the Part B billing data. And we calculated the frequency of the special visits per capita for each county. And I think most of the maps that we made is numbers of visits per 1,000 or per 10,000 people. You really have to look at equity. You can map it out and say where all your visits go, and that will tell you your reach, or you translate it per county as a population rate, and that will tell you the equity because that gives you a good map to really begin to develop strategy, county utilization rates. And that was not my idea, but we broke them into quartiles. And that was my management colleagues' idea because they wanted to see who was on the bottom, who was next, who was in the middle, and who are the outstanding outliers. And this is the result of our analysis. And guess what? The red counties are the ones that are in quartile 4, that are the lowest. So these are visits per population. And so we could see and we could calculate from these numbers how many visits we should deliver by telehealth in order to move that county out of the bottom quartile, the red one. Ryan is showing us Marion over there. In Marion, we need to do in 1 year 2,459 visits in order to move Marion from red to orange. And that is something that's measurable. It's something we can plan for. It's something that we can say have a strategy, and we can see next year if we have accomplished it. And it doesn't have to be done in a year. It can be done over the strategic period of a plan. So this is really what we looked at for specialty. And this was just the specialty utilization across the total groups. Next slide, Ryan. The next thing we looked at was value strategy for hospital support. We wanted to identify the gaps in access to specialty inpatient care. And you actually ended up having to use 2 different data sets. First, we used the same Medicare National data set that I remember I told you it was pretty thin. And we pulled out all the Part B bills for hospital admissions. And we picked neurology because we wanted to see, we have a big teleneurology program. We wanted to see what was going on there. And then we pulled the diagnosis codes for those consult visits. And I took those diagnosis code and I took all our hospital admissions for South Carolina for 2018 and 2019 and pulled those diagnosis code out and mapped them per 1,000 patients per county. And that way we could see which patients, which counties actually got a similar level of access to neurology hospital admissions, and which counties we might need to supplement with telehealth visits for this area. So we were really looking at county demand and county supply to try to calculate a service indicator. So we could calculate again by quartile numbers of visits needed for counties to advance to the next quartile. And here you have it based on 2 years of Medicare data and 2 years of hospital admissions for neurology services in those South Carolina counties. And if you look at it, there's a large variation between the county supply in the county service indicator. The light one, the light touch blue ones are the bottom quartile, and the dark blue ones are the top quartile. And so our goal is to move the light blue ones into the medium blue ones and keep the dark blue ones at the level that they are. Next slide, please.
I was just going to chime in here to say a good example of how this might end up getting used is, you know, as MUSC builds the Black River Hospital right here in the Lower Florence, kind of Williamsburg area, it's going to be heavily telehealth enabled. And so this could be a place that we could help move the needle by addressing that gap through that telehealth program. Okay.
Yeah, and if you think about it, if we want to do telehealth sites, we want to locate them so that we have in telestroke, we have hubs and spokes. And in teleneurology, if we think about hubs and spokes, we want to put some spokes in the light blue areas. And so we want to enable those areas. We want to reach out. That's where we want to focus. We certainly don't want to focus where it's easy to do, where there's already a high demand in all the dark blue ones, because they're being well reached and well served by the providers that they already have. So the next thing, and this is really much more Ryan's area to talk about, and we are looking at the value strategy and the convenience of care to identify gaps in access to virtual urgent care using the MUSC virtual urgent care databases, and the CDCs, the Centers for Disease Control, social vulnerability index. Let me just talk a little bit about the social vulnerability index and then give it over to Ryan. It is an index developed by CDC to decide which geographic areas, specifically which counties, during a hurricane, an emergency such as a hurricane and an earthquake or a fire, they should deploy their rescue groups to first, because they have a highly they have a population that does not have very many resources and a community infrastructure that are not necessarily optimal. And so it is based on 4 different indicators that are related to income, poverty, population composition, such as how many elderly people are there, how many people under the poverty limit, how many people of racialized minority groups, how many people with unemployment, and are there food deserts in there? Are there people who have lack of transportation, even though they're working, they don't have access to public transportation or a car? And it is all brought together in an index. And I took this index and I calculated the counties where over 90% of the population fell into a high need area defined by CDC's Community Vulnerability Index. And we glued that on the data. And then Ryan took it from there. And Ryan, you take it from here now.
Sure, yeah. So as Kit was mentioning, I think, what's important, or I mentioned this early on, we have used our virtual urgent care platform during COVID to try to get better screen folks for COVID symptoms and then triage them to care. So as a public health intervention, it was important for us to understand who's using it, and if there are gaps in care, as Kit mentioned, what can we do to mitigate those gaps of care? So what we did in this next page, you'll see, we took the Tri-County area, Charleston, Berkeley, and Dorchester, because other health systems in the state were also using virtual urgent care. So we felt like this was really the place where we had the most saturation and it would make the most sense to look. And what we did was we mapped, similar to the other discussion, based on zip code, the utilization patterns per capita. And so over here, you can see that the folks with the darkest, the zip codes with the darkest blue were the highest quartile, the highest utilizers of the virtual urgent care platform. And this is kind of the central Charleston area. Whereas folks in the lighter blue used it the least. And again, this is adjusted by capita, so it takes into account the fact that Charleston is more populated. So what we did was we made this map, but then we wanted to look similarly, looking at the conversions Kit had done with the Social Vulnerability Index and the scores of social vulnerability to see what that looked like. And so what you can see here is it's really a complete inverse of the other picture, showing that the lower utilizers of virtual urgent care were actually the most vulnerable individuals. And so this is not surprising to us, but it does make the case whether it's for either developing alternative interventions to help facilitate COVID triage to testing, or to think about how we are deploying our current platform and figure, is there digital literacy training that is needed in these communities? Is it broadband? Is it access devices? If telehealth is going to be a main use to kind of advance healthcare, what changes need to be placed or made in these more vulnerable communities to get their levels of utilization up to more equitable? And so that's what was interesting. We did this project, but there's a study done similarly looking at COVID cases in New York. And what the map on the left looks at is the virtual urgent care visits. And then on the right, it's actually where COVID was happening. And you can see that similarly to New York, it was the more kind of affluent, least vulnerable areas that had the higher utilization when actual COVID cases were occurring in other areas. So again, it kind of echoes this message that additional interventions are needed if we're going to move the needle in equity using telehealth. Anything you'd add to that, Kit, before we wrap up?
No, I think it's very important to understand, and one of the really nice things about the 2 grants that we're reporting on here is that the HRSA Center of Excellence grants has facilitated the development or facilitated using our time to develop a tool such as the CDC Community Vulnerability Index at the zip code levels. Because most of us who do telehealth, our patient data is by zip code, and so we couldn't use the county codes because counties and zip codes do not overlap. And those data are now available as zip codes, and they're data that are available to you guys should you need it. All you have to do is ask. And those are the resources that will be available. Once we get our new website up and running, it'll be available to pull down from there. But until then, just ask and we'll send you the data.
And to that point, these maps, they've already been shared with our SCT Advisory Council, and there's been some really fruitful discussions. And as we go into our fall strategic planning, we're going to be providing some of the other health systems with this breakdown of county and zip code scoring so that they can use their own administrative data to see what their maps look like and where there may be disparities. It's also kind of informing where we're moving and placing schools, or where we might be moving to place regional telehealth clinics. So lots of opportunities to see these maps, and then what I'm excited about too is to look at these maps in 2 to 3 years and see how they've changed, hopefully, because of telehealth. So in the interest of time, I think we should probably wrap up and hand it over to Dunk. I do want to kind of acknowledge some of our other team members who played a big role in helping shape some of this discussion. But with that, I'm going to hand it over to Dunk. I'll introduce him, and while I'm introducing him, Davia can give him control of the slides.
Ryan, my volume went out. Can you hear me?
I can hear you. I muted myself on accident, and I apologize for that. I'll start your intro over. So Dunk Williams is an associate professor of healthcare financial management at MUSC in the College of Health Professions. He enjoys teaching healthcare finance and accounting courses to students in master and doctoral level programs of health administration, where he embeds policy-relevant healthcare financial decision-making into the classroom. His research focuses on various financial aspects of healthcare management and policy, with recent work investigating telehealth and hospital mergers, particularly among rural populations. We're going to hear more about that today. Dunk's PhD in healthcare financial management is from UNC Chapel Hill. He also has an MHA from the Medical University of South Carolina and a Master's of Theological Studies from Duke Divinity School and a BS in accounting from the University of South Carolina. He's a key member of our Center of Excellence team, and I'm happy to have him take over.
Thank you, Ryan. Welcome, everyone. So a lot of great discussion where we are here in Dr. Brown's presentation on perspectives and understanding what key informants are saying about our area of telehealth has been very important. And then what you just heard in the last presentation too around the heat mapping, these are just great skills and different ways of coming at how can we improve and measure and evaluate telehealth. And I'm also going to present a very different way too of what we've been doing. But welcome everybody, and also Davia and our Palmetto Care Connections folks, thank you for hosting this. These are always great. So I'm going to focus the next few minutes on 2 things. Since this group is largely a group of South Carolina healthcare executives trying to improve telehealth in our state, and also because some of our work has been around, a lot of our work's been around rural healthcare and rural hospital finances, I'm going to focus on what are currently what are our rural hospitals looking like and compare them to other rural hospitals across the nation and then U.S. averages. And then I'll talk a little bit about one project we've been doing relative to rural hospital finances and telehealth. So, rural hospitals. On this slide and the next slide, I'm going to provide some descriptive information for 3 categories. This, again, South Carolina rural hospitals, the other 49 states of rural hospitals, and all U.S. hospitals, the averages, okay? So column 1 here is what I'm going to focus on. I'm going to do this over 2 slides. You can read summaries that I try to put on a lot of these data points as we go along. But so South Carolina rural hospitals, 27 of them in the state compared to roughly 2,200 U.S. rural hospitals and 4,500 hospitals across the nation, rural and non-rural. Our hospitals are more government-owned, and there's a lower proportion that are critical access hospitals. So most of you are likely familiar with that designation, but the critical access hospital designation is typically smaller hospitals and less than 25 beds. Geographic distance is a factor, and there's different cost-based reimbursement. And so cost-based reimbursement, that's going to have an impact on some of the financial metrics that we're going to talk about today. Bed size, as we measure size relative to bed, revenue, which I didn't report here, overall inpatient discharges, all those measures, we look at our rural hospitals in South Carolina, and we're seeing that the hospitals are indeed larger, okay? So larger beds, these are median values here. Also the number of discharge equivalents, these are inpatient, and revenue, again, I didn't report here. Now, looking at a couple of measures, potentially of managerial efficiency, discharge equivalents per FTE, full-time equivalent. So inpatient discharges, our South Carolina rural hospitals are roughly on average with national averages, and they are discharging more per FTE. That can be a sign of potential higher efficiency in how many discharges per staffing, so how much staff is being utilized. That relative also to our case mix index. And if you follow along with my cursor here, case mix index slightly higher in the compared to other U.S. hospitals too. So that may be an indicator that it's not simply due to differences in case mix. Cost per discharge is slightly lower in the South Carolina group. Higher occupancy than other rural hospitals and below the national average. This is about on pace with what we expect to see in similar length of stay. Now, looking at some of the financial measures, these columns are going to be for the same groups here, but margins, profit margins, total margin, which operating margin is your direct core services the organization providing. Your total margin is going to include non-operating income, investment income, grant revenue as well. Those are going to be in this category, and we see slightly negative profit margins. Again, our year period, these are for the past 5 years of reported data, 16 through 20, we'll have on hand here. And so slightly negative margins compared to U.S. rural hospitals, and then also looking at national numbers here. So in the national non-rural hospitals, as many of you are aware of, those profit margins are higher than what we're seeing when you average across all of our rural hospitals too. Now these numbers, these are unadjusted characteristics here. Because South Carolina hospitals, roughly 4 of the 27, 4 of them are critical access hospitals, but because we're reporting a lower proportion of critical access hospitals, these numbers are not adjusted by critical access status. Across the U.S., critical access hospitals, largely associated with the enhanced reimbursement, the cost-based reimbursement, do report higher profit margins in recent years. And part of that goes back to the inception of the critical access designation, the 1997 designation and that reimbursement, and the solvency goal of that program. So if we adjusted for that, these numbers would not be too far off from what we're seeing on national averages. Now, days cash on hand, I'll come back and talk about this here shortly. Days in net accounts receivable, how quickly are our organizations collecting? We're seeing 53 days here, slightly higher than some of the national averages, and so that's an efficiency measure where there are slower collections on average. Salary and benefits is about on line. These are not wage adjusted. The last 4 measures I'm going to highlight here are capital purchases, specifically on annual capital purchases. And we see that total capital purchases are larger for our South Carolina hospitals. I'll show in a few slides that when we adjust that by a size measure, that they're roughly spending the same amount on capital purchases. Our South Carolina hospitals are investing more in land, more in buildings, and less in land and health information technology. So these are a couple of factors here related to capital purchases. And some of these they can differ on a variety of factors too, based on how it's recorded. Now, let's just look on an average annual basis for a couple of these measures. For profits, total and operating margin, again, just showing the red line. You can read my key messages as we go along, or you can also follow along with the graph of my cursor. But the red line is showing slightly lower profits of South Carolina rural hospitals compared to the blue line, other rural hospitals, and the green line, the U.S. national average. cash on hand. I said I'd come back to this. And so South Carolina hospitals are following roughly the national average. And then in 19 and 20, we start to get distorted numbers here. And then our other rural hospitals, we do see correlation with the size of the hospital and the amount of days cash on hand. That roughly follows organizational dynamics. What I'm going to highlight here is in 2020, I expect a lot of differences around profitability, cash in particular, cash as well, for how hospitals are reporting. And that's something that we on a research standpoint are going to be adjusting for and accounting for in years to come. And why is that? Well, we have the CARES Act funding, okay? So the PRF funding and the PPP funding, and as those come in and also when those are recognized. And 2019, we start to see some spike here. My expectation on that is possibly around differences in fiscal year close dates. So for hospitals whose fiscal year closed March 30th through June 30th of 2020, that would be classified as a fiscal year 2019. So we might already see some of the recognition of that cash coming in at that point. Spending relative to size here. So just adjusting for a couple of things. So average salaries and benefits. Salary and benefits can be the largest expenditure for any healthcare organization, virtually any organization. Right here, South Carolina is roughly around averages for these, but I do want to highlight the y-axis here. So we're seeing that organizations, the national average in green is roughly close to 40% of all expenses are salary and benefits. And on the right side, I want to highlight administrative and general expenses. So administrative and general expenses, we do see, this is over a 10-year horizon here, slightly higher administrative and general expenses for rural hospitals in South Carolina. Now, another interesting thing around this is not just South Carolina, but the green line, the U.S. national average, from 2011, roughly 14%, till 2020, roughly 16.5%, 17%. We've seen a general increase in the proportion of administrative and general expenses relative to revenue, one measure here, but so we've seen that proportion increase. This is strictly observational data here, so this is, I'm not implying anything with this too, so this doesn't reference is that anything around efficiency. And so how is that being used? Is A&G, our administrative and general expenses, assisting with greater revenue generation, productivity, and efficiency? Another thing that is interesting about this is because the blue line consists of a higher proportion of critical access hospitals, and again, based on how the reimbursement is set up, I would have expected the blue line to, in general, be higher than most averages. So that's something that could be interesting and relative to future projects. But providing you a lot of this data for what are South Carolina rural hospitals, particularly because of who the audience is today. But so this is very important as we work on research projects, as we look at telehealth and telehealth implementations, potentially pairing with other projects, as you've seen from our first three presenters today too. Very relevant, state, federal, local policymakers, key decision makers like the folks on this call, hospital administrators, healthcare administrators, providers, board members, and also patients. So as we come back to the overall goal of better quality, better access to care, and doing that the most efficient way would be strong financial management. One project I'm going to highlight here, from a research standpoint, we have partnered with the University of Mississippi Medical Center, UMMC, in evaluating their teleemergency program and a couple of projects that we've conducted. And so I have a busy slide here. I'm going to tell you where to focus here in a minute, but this project is investigating financial and operational performance of those hospitals that have participated in the state of Mississippi, rural hospitals. Teleemergency is a telehealth emergency implementation. It started in 2003, so we have plenty of time to evaluate this, and there's 21 hospitals that participated. As we looked at a variety of indicators, one of the biggest things that we're seeing, and we're still conducting research around hospital mergers associated with this period, but the number of closures of hospitals is lower than the number of closures for non-participating rural hospitals in the state of Mississippi. Now, there have been 2 closures that participated, but based on key informant interviews and working with folks at the University of Mississippi Medical Center, those hospitals' financial performance was very low, and they were near bankruptcy prior to participating in this program. So in the past several years, there haven't been any closures associated with programs that have participated in this implementation. So this implementation, whether it moved the needle around financial and operational metrics that we've looked at, big picture, from what the goal of the program was, is that it has led to long-term sustainability for 20 rural hospitals in the state of Mississippi. And so this comes from prior paper where we looked at ED charges associated with these hospitals. But we categorize some of the motives, and I'm going to highlight numbers 3 and 5 here because the goals were to maintain access to care and do so in a financially strong way. And so it's done so, that program, for many of these hospitals, and it's also mitigated the investment. So as I have not just rural, but also non-rural stakeholders on this call, very important to consider if you're considering acquisitions or partnering with rural healthcare facilities, because telehealth, various implementations may be relevant for doing so in a way that doesn't require a full acquisition or a joint venture. So thank you. Very thankful for our funders, many folks who participated in these projects. Our list of references are available, but I'm going to close with this and also talk about the summit and open it for questions. But I'm highlighting pictures, mostly 2 from Google Earth, of 4 rural hospitals. I'm from rural South Carolina, and a lot of my passion with rural health drives from, this is a Google Earth image a few years ago of the rural hospital that's now out of business in my home county, the only hospital county in that county. Here's another rural hospital that was merged in a different state. It was acquired, and then it was closed. Here's a third rural hospital, bottom left, that was acquired by a health system, and they received a lot of capital investment. They've got a new facility, and in this facility, they literally are turning away some dollars by having a triage that triages patients to either urgent care or the rural ED based on capacity and based on what the patient needs are. And the fourth is an example of an MUSC rural health tele-emergency implementation. A lot of opportunities for us. So we'll close with this and then look forward to questions. And also, my information is here. Please follow up with me after.
Thanks so much, Dunk. Really appreciate that. We do have about 5 minutes. We have a few questions in the chat, and I'll kind of pose those. Some of those are for some of our previous speakers. So Dr. Simpson and Brown, if you can hop on as well, that would be excellent. The first question is about, someone asked, if we say that telemedicine is here to stay, have the various insurance companies accepted telehealth and made reimbursement possible? So I can speak briefly to that, and I would encourage the questioner to feel free to reach out to me individually. We actually have a SCTA sustainability work group that works closely on reimbursement issues, but we are encouraged by a lot of progress that's been happening. The most recent physician fee schedule that came out from Medicare was very favorable, indicating a lot of the telehealth flexibilities will last for the next couple of years at least. From our state Medicaid just released a bulletin that was very favorable to outpatient direct-to-consumer video visits. That's here to stay. And then Blue Cross Blue Shield, which is the largest private payer, also has adjusted their policies and actually had favorable policies even before COVID for direct-to-patient. So a lot of the reimbursement landscape is moving towards telehealth being here to stay. That said, we are still working towards codifying that in state legislative language so that health, our various health systems can better plan for the future and know exactly what that looks like. But happy to get folks involved in that conversation if they want. 2 other questions related to heat mapping. One, Kit, for the outpatient specialty heat map that we showed, the question is, what specialty does that include? And that was neuro, I believe. Can you confirm?
Yes, that was neuro, but we do have the data to do internal medicine, cardiology, neurology. We did neurology, endocrinology, infectious diseases, rheumatology, psychiatry, and surgery. So we can do those. I run the data. We haven't quite gotten to interpret them and map them out. But if you're interested in any specific specialty, just contact me or Ryan.
And one more question came through asking, have you done any spatial analysis to examine the associations between geography or community level characteristics and rates of change in healthcare outcomes?
We haven't done the spatial analysis because we need data over time, and I needed a density of data, so I had to combine 2018 and 2019. I didn't want to use our 2020 data because there were so many permutations. We can't really depend on it for baseline, but that is a very important thing to look at trends over time, because there we can look at losses. And I think, thank you for that idea. We'll put it in as part of our objectives.
Thanks, Kit. And we only have 1 minute left, so I think I'll close there and instead of offering more opportunities, but I know all of our speakers would be very happy to kind of chat with folks afterwards. The slide that Dunk is sharing right now is showcasing the summit. And so as folks know, Palmetto Care Connections always throws a wonderful conference, bringing together lots of different leaders in the telehealth space. To me, it's one of the best parties in South Carolina that happens. But the registration is open. And one thing I want to note is that we are having a special kind of telemedicine research and reports live in-person session where we'll be sharing some of the findings from some of our other projects going on. Some of these include a deeper dive into the virtual urgent care space. Dr. Brown and myself and some others are doing qualitative interviews with folks who have experienced audio only versus in-person telehealth to get at some of that, which is a very large topic going on right now in the telehealth space. And we'll probably have lots of other sessions as well. And I think one of the most exciting pieces of this session too is we want to hear from you. We want to hear what are the research topics that are bubbling up in the community that you want to partner with us in looking at, or that you think we should incorporate into our Center of Excellence work plan, because we want this research to really be embedded in making change in the healthcare system here in South Carolina. So register, reach out. We'd love to see you there. If not that, shoot us an email. We'd love to hear from you. Thank you again to Dunk, Kit, and Elizabeth. And thanks again to PCC for hosting us. Davia, anything to close us out?
No, just a brief reminder that this webinar has been recorded. So the webinar recording will be available after the webinar has ended. The slides are also available in the handout section of where the navigation bar is under the questions. The webinar slides will also be posted to PCC's website. Again, thank you all for joining. Thank you to each and every one of our presenters today. I am looking forward to this session at the summit in Charleston, South Carolina on November 9th and 10th. Y'all have an awesome day.
Thank you.